Social connection. Okay?
Hello.
Hi, Dr. Bradoo. Do you hear me?
Yes, I can hear you.
Yes, we are very happy to
Yes,
have
I
you
can
with
hear
us.
you.
We are very happy to have you with us online. I hope next year you will be physically with us. The weather is marvelous these days in Alexandria. Sorry for the delay, but now you are going to present your topic on the frontal sinus, and we will let the questions at the end of the session. Welcome you again, and thanks for your cooperation.
Hello. At the outset, I'd like to thank Professor Sami Alwani, Professor Ahmad Al-Ibrahim, Professor Aman Al-Madani, and Professor Ziad Mandoor for inviting me to share my views. It's a pleasure to be here at this conference. We're going to talk about treading on eggshells, surgery for the frontal sinus. What I hope to do is answer this question: how does one operate on the frontal sinus safely and effectively at the end of this lecture? Safely is very easy, just don't go there and it's very safe. The fact is that once one attempts to open up the frontal recess, one should do it effectively so that there is no chance of recurrence of disease. And that's what we're going to address today in this lecture. That is the Sistine Chapel in Rome, and you can see how beautifully the roof has been painted by Michelangelo, and the beautiful proportions and the beautiful pictures. This, for the ENT surgeon, is his Sistine Chapel and the roof. And we must, at the end of surgery, see this kind of frontal recess at the end of surgery so that we know that we've done a good and complete job. So what are the challenges for frontal sinus surgery? Well, the first thing is that the frontal recess is like our fingerprints. It is very variable in anatomy. No two people have the same type of frontal recess. And also it's very precarious anatomy. It lies in the region between the orbit and the brain, so to say between the devil and the deep blue sea. And insinuating one's instruments and operating in this narrow zone between the orbit and the brain is where the challenge is. The first thing one should do to become confident about frontal sinus surgery is to study the anatomy. And we are going to discuss the anatomy, the relevant surgical anatomy of the frontal recess a little bit before we actually start discussing surgeries. So one can study anatomy with the CT scans, with the bones, with sagittal sections, and endoscopic anatomy. And only when one has done that can one actually very confidently then go on and proceed towards surgery. So in this lecture, we will begin with discussing the frontal recess. Now, the anterior wall of the frontal recess is the anterior wall of the agonized cell, which means that the entire agonized cell lies within the frontal recess. And so once you've entered the agonized cell, you are actually within the frontal recess. The posterior wall of the frontal recess is the anterior wall of the bulla, this area. The lateral wall is the lamina papyracea. The medial wall is the middle turbinate. And lying within the frontal recess is the uncinate process and various types of frontal cells. The frontal sinus tapers down like this to a narrow infundibulum. This is called the infundibulum. And though we now call the entire frontal sinus outlet as the frontal outflow tract, but for the ease of understanding, the narrowest part, the waist of the frontal outflow tract is what, for the ease of understanding, I've called the frontal ostium. And then you have the frontal recess. So the frontal infundibulum, the frontal ostium, and the frontal recess together form that classic hourglass that we talk of so often in frontal sinus surgery. So once again, the anterior wall is the anterior wall of the eager, the posterior wall is the anterior wall of the bulla, and the content is the uncinate and the frontal cells. If we were to look at the frontal recess, completely dissected out frontal recess endoscopically, what one would see is this configuration. Anteriorly, the frontal sinus, behind that, a cell-like structure, and then behind that, the anterior ethmoidal artery. This is the configuration which one would see at the end of a complete surgery. If you want to look at the same thing on a bone, on the frontal bone, most anteriorly would be the frontal beak, which is solid bone and which forms the floor of the frontal sinus. This is the frontal sinus. This is the cell-like area behind that. And this is the anterior ethmoidal artery. If we were to look at it sagittally, this would be the part of the frontal sinus which is seen endoscopically. This cell-like structure which is seen behind the frontal sinus is actually the posterior wall of the frontal recess. It's the skull base. And behind that, lying at the level behind the anterior wall of the bulla, would be the anterior ethmoidal artery. So the frontal sinus, the posterior wall of the frontal recess, and the anterior ethmoidal artery. Now, how does one know on CT scans, when one is looking at CT scans, that we have transited from the frontal sinus to the frontal recess? So when we take a cut through the frontal sinus, it also goes through the frontal beak in this way. And so the CT scan in coronal will show bone extending from one end of the orbit, from one lamina papyracea to the other lamina papyracea. That entire bone is the frontal beak. It's also sometimes called the T sign. That's the perpendicular plate of the ethmoid in the septum, and that's the frontal beak, and it forms the T. It's also sometimes called the double arch sign. As you can see very classically, two arches form, that's the double arch sign. Now, as one reaches the most posterior part of the frontal sinus, the frontal outflow tract or the frontal ostium lies right at the posterior end of the frontal sinus and at the most medial end. And so when one goes through the frontal recess and the frontal outflow tract, one has already gone behind the frontal beak, and therefore in the frontal recess, one sees that the bone extending from one lamina papyracea to the other lamina papyracea is absent. So one knows that we are in the frontal recess area. Now, the next thing that one needs to check on is whether the frontal recess is narrow or is it wide. That's very important because a lot of the prognosis quite often depends on that. There was a time when we felt that having too many cells in the frontal recess was not such a good idea, and that it would be difficult to operate. But the fact of the matter is, the more pneumatized the frontal recess is, the more cells there are in the frontal recess, the better it is. Why is that so? Now, if you have a very narrow frontal recess with no cells, that means the frontal beak is completely solid and not pneumatized. Then at the end of the entire dissection of the area, the space of the frontal outflow tract would still be quite narrow between the skull base. So the distance between the frontal beak and the cribriform plate would be very narrow, and you would have a narrow frontal outflow tract even though you had completely cleared whatever disease is there. Whereas if you have a pneumatized frontal recess with lots of frontal cells, then these frontal cells are formed due to the pneumatization of the frontal beak. And when all these cells are removed, finally, the distance from the frontal beak to the cribriform plate is much wider. So the frontal recess after complete surgery is much wider and therefore much less likely to close down. Therefore, pneumatization of the frontal recess is a good sign, and that post-operatively you will have a healthy, well-healed frontal recess as compared to a very narrow frontal recess with no pneumatization. The next thing that we look at is whether there is an agonized cell present or not. For example, here on the left side, there is an agonized cell. On the right, there isn't. This is very important because the approach that one would take to the frontal sinus, at least the way I operate, the approach I take to the frontal sinus differs depending on whether there is an agonized cell present or there is an agonized cell absent. That means there is no agonized cell. We'll come to that in a little while. Now let's discuss one more aspect of anatomy, and that is the frontal cells. So the first cell which is seen on CT scan before the middle turbinate comes up is the agonized cell. So even before the middle turbinate, you can see the agonized cell. Then the middle turbinate comes up. And then if there is one cell above the agonized cell, but it lies below the level of the frontal beak, this is a type 1 frontal cell. If there are 2 or more cells, but above the agonized cell, but they all lie below the level of the frontal beak, then this is type 2 frontal cells. If you have a cell which extends above the frontal beak into the frontal sinus, then it is either a type 3 or type 4 cell. If the cell extends above the frontal beak, but less than 50% of the height of the frontal sinus, then this is a type 3 frontal cell. And if a frontal cell extends above the frontal beak so high into the frontal sinus that it is more than 50% of the height of the frontal sinus, then this is the type 4 frontal cell. Now it's very easy to mistake a type 4 frontal cell. During surgery, endoscopically, it's very easy to mistake a type 4 frontal cell for the frontal sinus. Now, the two differentiating points between a type 4 frontal cell and the frontal sinus is that the type 4 frontal sinus has no scalloping or no hostrations like the frontal sinus. And most importantly, the posterior wall of the type 4 frontal cell is concave. So it's like looking into the inside of a pot, and the posterior wall is concave. If, on the other hand, you are in the frontal sinus, the posterior wall is always convex towards you because of the bossing of the frontal lobe. So these are the 2 points of differentiation between a type 4 frontal cell and the frontal sinus seen in the let's have a look at it in the sagittal section. So if this is the agonized cell, that's the bulla. This is the agonized cell, 2 cells above it, but below the level of the frontal beak, like this, 2 cells, but below the level of the frontal beak. The frontal beak we had already spoken of extends from one lamina papyracea to the other. So 2 cells, this is a type 2 frontal cell. A cell which extends above the frontal beak into the frontal sinus, but less than 50% of the height of the frontal sinus is a type 3 frontal cell. Whereas if it extends for more than 50% of the height of the frontal sinus, then that's a type 4 frontal cell. Occasionally one can see an isolated frontal cell. Well, no frontal cell can actually be isolated. They all have to drain into the nasal cavity. But very often, this is a cell which we call the frontal bulla. So it can, this kind of isolated cell can either be a type 4 frontal cell in a cut, or it can be a frontal bulla. Now, all the cells type 1 to 4 usually pneumatize anteriorly by pneumatizing the frontal beak. But occasionally a cell may pneumatize along the posterior wall of the frontal sinus from above the area of the bulla. And therefore, this cell, which pneumatizes into the frontal sinus along its posterior wall, is the frontal bulla cell. And besides all these cells, you can also have an interfrontal septal cell, that between the two, that the septum between the 2 frontal sinuses itself may be pneumatized. And an interfrontal septal cell is quite often associated with the pneumatized crista galla as well. So Peter Wormald came out with a very good classification, which actually is much simpler to remember and much easier to understand as a concept. And sorry. So he divided the frontal cells into agar, supra-agar, and supra-agar frontal, which means that this is the agar nasi cell. A cell above the agar nasi cell, but below the frontal beak, was called the supra-agar cell. And if the cell went into the frontal sinus above the frontal beak, then it was called the supra-agar frontal cell. So supra-agar frontal cell would be the type 3 and type 4 frontal cells. Also, you could have the bulla, a suprabular cell which lies above the bulla but below the level of the frontal beak, and a third cell which goes suprabular frontal, that means lies above the bulla and going well into the frontal sinus above the frontal beak, and that would be similar to what was discussed as the frontal bulla cell. So this is the suprabular frontal cell that we are talking about. The uncinate process is the content of the frontal recess, and so we'll discuss that now. The uncinate recess process in 80% of the cases attaches to the lamina papyracea, like this. And therefore, the frontal outflow tract usually drains medial to the uncinate, that is between the uncinate and the middle turbinate. This happens in almost 80% of cases, and one must remember this while operating. And the uncinate, where it attaches to the lamina papyracea, there is a blind recess, and that's called the recessus terminalis. Now, in the remaining 20% cases, one may have the uncinate attached to the middle turbinate or attached to the skull base, in which case the frontal outflow tract would open lateral to the uncinate process. But this is less common. Only about 2 out of 10 cases would be like this. Let's also now discuss the concept of the suprabular recess and the supraorbital cell. So what exactly is the suprabular recess and what is the supraorbital cell? So this is the bulla. These are the frontal cells. The bulla is usually attached to the skull base and right up to the skull base. But occasionally it may fall short of the skull base, and then there is a space between the bulla and the skull base, which is called the suprabular recess. Now, there is also another cell which lies behind the frontal sinus. It is completely separate from the frontal sinus. It pneumatizes the orbital plate of the frontal bone, and therefore on CT scan, it looks very much like the frontal sinus, but it is a separate cell lying behind the frontal sinus, separated from the frontal sinus by a thin partition. It also drains not into the frontal outflow tract, but into the suprabular recess. And it is at the mouth of this cell that one usually finds the anterior ethmoidal artery. So the supraorbital cell is a cell behind the frontal sinus, separated from it by a thin septum, and it drains into the suprabular recess. And the anterior ethmoidal artery is usually seen at the point where the supraorbital cell is. So this is the CT scan where we are looking at the anterior ethmoidal artery. The anterior ethmoidal artery is of great concern to the novice endoscopic surgeon, one of his major concerns. So I'm addressing it early in the lecture, that the anterior ethmoidal artery is seen as a beak like this, going across. This is the orbitofrontal canal. It's usually seen at the junction of the medial rectus and the superior oblique. Now, it may run in the skull base, or it may be exposed and seem to lie low. Well, it's not actually the artery which is lying low. The artery is exactly in the same place as it should be. It's not that the artery came low, it's that the nose went high, which means that when the skull base gets pneumatized at the level of the anterior ethmoidal artery, it is exposed in the nose, appears to lie well exposed in the nose. And this cell, which goes above the anterior ethmoidal artery, which looks very much like the frontal sinus, but is above the orbit, is the supraorbital cell. So this is what I was talking about, that the supraorbital cell is at the level of the anterior ethmoidal artery. Now, the other challenge, of course, is the hand-eye coordination and the instrumentation. So usually a lot of surgery all the way up to the sphenoid is done with a 0-degree endoscope. But for the frontal sinus, we need to use angle scopes. And you can see what is the difference. It's the same recess, but you can see the difference in visualization that you get when you start using an angle scope. The other issue for a novice surgeon is that the instruments are moving in an anterior-posterior direction with a 0-degree endoscope, but with the angled instruments, the instruments are moving in and out of the nose, but the tips are moving up and down. So the instruments are in the x-axis while the tips of the instruments are operating in the y-axis. So this is why one can have difficulty with hand-eye coordination in one's initial years. The important thing that I do while doing frontal recess surgery is that once one starts operating on the frontal recess, usually we have the, endoscopic surgery, we keep the head semi-flex. But when I start operating on the frontal recess, I extend the head so that the access to the frontal sinus is better. And one can use the 0-degree endoscope for a little longer before one shifts to a 45 or a 70-degree telescope. The important thing to remember is that after the surgery after the frontal recess has been operated on, one must remember to flex the head so that one doesn't accidentally go through the skull base. With the 0-degree endoscope, of course, we use the instrument below the scope. But with a 70-degree, it's better to use them side by side so that one can find ease in operating. The other thing is very angled instruments like the giraffe forceps. One would insert them into the nose like this and to reach the frontal recess easily, and would, when removing them, rotate it in the opposite direction and remove them in this way without causing much mucosal trauma. Now, what do we mean by uncapping the egg? So Sternberger was the person who spoke in great length about eggshells and uncapping the egg. So this is an egg cup, and within it sits an egg. So let us assume that we turn this upside down. So if we turn this upside down, we have a frontal sinus. So this, just for the sake of imagination, is the frontal sinus. This is the area of the frontal ostium, or the narrowest part of the frontal outflow tract. This is the frontal recess. And sitting within this frontal recess are eggs. So the frontal outflow tract is blocked by these eggs, and it is necessary to remove these eggs so that the frontal outflow tract is actually in here, just a potential space between the egg cup and the egg. So that's what the frontal outflow tract, even in the human being, is. It's very often very narrow and just a potential space because the frontal recess is occupied by various cells, or as in this case, we're talking about like eggs. So what is this egg? What exactly is this egg or this eggshell sitting there? So what is this shell? So shell could be either the upper part of the uncinate process. It could be upper part of an agar cell. It could be the upper part of a frontal cell. And sometimes it can be the upper part of a cell like the type 3 or type 4 frontal cell, which has gone well within the frontal sinus. So these are the various eggs or cells sitting in the frontal recess. And these are the ones which need to be decapped or removed one by one so that the frontal outflow tract is completely opened up and stays mucosalized. So let's assume that that's, like I said, the agar cell. These are different cells sitting here. So let's assume that this is the frontal recess. These are the eggs obscuring the frontal outflow tract. You can see it's a very narrow tract, and it's obscured because of these cells. So the correct thing to do, and this is one message I'd like to give, is that when one is removing these cells or uncapping the egg, so to say, it is necessary to operate with, and usually we are doing it with a Kunz probe, the Kuhn's probe should be made to go very close to the middle turbinate, from close to the middle turbinate, like this, and then go above the eggshell and pull it down. So this would be the right way to do it. Now, the concern is that if we stay close to the middle turbinate, we may accidentally perforate the lateral lamella of the cribriform plate and cause a CSF leak. Now, it's very important that when one stays close to the middle turbinate, that the instrument is always directed laterally and anteriorly. So the direction of the movement of the instrument should always be laterally and anteriorly. If one does that and one uses a Kuhn probe delicately, without force, there's almost negligible or no chance of damaging the lateral lamella of the cribriform plate. So I'll show you that during the surgeries, but what one shouldn't do is actually stay away from the middle turbinate and go through the frontal cells like this. Because if one does that, what one is left with is a whole lot of cells like this, and one can get quite lost in amongst all these shells trying to find the frontal sinus. So better always to go one shell at a time, staying close to the middle turbinate and uncapping the eggs as you go, taking care to see that the instruments are always directed anteriorly and laterally. So let's have a look at this. So you see that this is an egg obscuring the frontal recess, and you can see that the probe is used to remove that eggshell. But as you can see in the thing, it's staying very close to the middle turbinate, but is directed anteriorly and laterally. So you stay close to the middle turbinate, but direct your instrument anterior and laterally away from the lateral lamella of the cribriform plate. The other important thing to remember is that always use a suction which is smaller, thinner, and narrower, so that it doesn't accidentally crack the lamella. There are 2-3 things to remember about the suction. One is use a narrow one. Second thing is, while suctioning in the frontal recess, don't go in with the suction open. Close the suction, kink the tube and go in with the suction closed, because if you go in with the suction open, you will suck in mucosa of the lining of the frontal recess and abrade it. Whereas if you close the suction, go into the front sinus and then withdraw the suction with it open, the mucosa will lie flat against the walls and will not get abraded. So that's the second thing. And I call that targeted suction. That means when you're operating a narrow recess, always go with it closed and bring it out open. So that's targeted suction. And of course, use a narrow suction, not a very large one. Now, I prefer the intact bulla technique for frontal sinus surgery, which means that I find the frontal sinus first before I remove the bulla. So after an uncinectomy is done and the maxillary sinus is open, before I remove the bulla, I find the frontal sinus. Now, most often people say that the reason for doing an intact bulla technique is that one wants to protect the anterior ethmoidal artery, which lies behind the anterior wall of the bulla. But and that's not really the reason why I would do that, because so they say that if you open the frontal sinus with the bulla intact, the anterior ethmoidal artery is protected. But the fact of the matter is that the bulla may not reach the skull base. There may be a suprabullar recess, and the anterior ethmoidal artery could be exposed anyway, and it could still be damaged. So the real reason why one leaves the bulla intact is that if the bulla is intact, then the only cell that you can open into, the only space you can open into anterior to the anterior wall of the bulla is the frontal sinus, or a cell in the frontal sinus area. So it's not possible to open into anything other than the frontal sinus if one stays anterior to the anterior wall of the bulla. However, so that's exactly how you would get straight into the frontal sinus. However, if the bulla is out, then you could either go into the suprabullar recess, you could go into the supraorbital cell, or into the frontal sinus. So there would be multiple openings around the skull base, and it can confuse the novice surgeon, because then he's not very certain which opening is the actual frontal sinus. So when the bulla is intact and you know that the anterior wall is intact, the chance of you're going into the suprabullar recess or supraorbital cell does not exist. And the only thing that you would open up would be the frontal sinus itself. So for example, that's the bulla, that's the suprabullar recess. In this case, you can see the frontal sinus anteriorly and behind the supraorbital cell. So there are multiple areas that you could open into, and therefore it's best to leave the bulla as anterior wall of the bulla intact, so that you have it as a marker in finding out your way to the frontal sinus. So there are two ways in which I approach the frontal sinus. So now that we've discussed all the basic concepts about frontal recess surgery, let's actually see how the surgeries are done. So if there is a large agar nasi cell, then I prefer to use Wormhole's technique, that's the axillary flap technique. So how does one make an axillary flap? So the first thing is, at the axilla of the middle turbinate, one infiltrates and then starts about 7 to 8 millimeters above. The incision starts 7 to 8 millimeters above the level of the axilla of the middle turbinate. You go about halfway down, halfway the length of the middle turbinate, all the way up to the bone. There are usually mucosal tags within the bone, and there's usually a suture line there. That suture line is between the frontonasal process of the maxilla and the lacrimal bone. So usually one can see this suture line. One tucks the axillary flap completely behind the middle turbinate, out of harm's way. Once that is done, then with a punch, you could remove the anterior wall of the agar nasi cell. Now, once you remove the anterior wall of the agar nasi cell, because the agar nasi is part of the frontal recess, then you remove the posterior wall of the agar nasi cell. And once you remove the posterior wall of the agar nasi cell, you are in the region of the frontal outflow tract. One must remember always to remove the medial wall of the agar nasi cell as well, and not leave it behind. And so you get quite an end-on view of the frontal sinus, and you can stay with a 0-degree endoscope a little longer with this technique, provided you have extended the head a little bit. So this is the way I would approach the frontal sinus if an agar nasi cell is present. Now, if an agar nasi cell is not present, or there's a very rudimentary agar nasi cell, then I prefer to use the uncinate process as a guide. So in this case, as you can see, this is the upper part of the uncinate process. That's the middle turbinate, the lamina papyracea. This is the right nostril. And you see how the ball point, the Kuhn's probe, stays close to the middle turbinate, but pointed anteriorly and laterally, as you can see, close. Now, this is another frontal cell. So after removing the uncinate process, this is a type 3 frontal cell, and we are uncapping it and removing the eggshell, so to say, so that the frontal sinus is exposed. And you see how the movement is anteriorly and laterally away from the lateral lamella of the cribriform plate. And once you remove that, the bone, as you see, no mucosa is removed. One can see into the frontal sinus area with normal intact mucosa. Now I'm going to show you one complete surgery which embodies all that that I have spoken about. So this is a frontal mucocele. Usually one thinks of frontal mucoceles as fairly easy to operate, but this frontal mucocele has not created a bulge inside the nose. Let me show you. So we begin by doing an axillary flap technique. Because there is an agar nasi cell, we remove the anterior wall of the agar nasi cell. So this is the approach via the agar. The posterior wall of the agar nasi cell is already dehiscent, and we probe around in the region of the agar cell to see whether we can see any bulge of the mucocele, but there is no bulge seen and there's no movement seen. And so now we remove the upper part of the uncinate. So behind the agar nasi cell was the uncinate. We are removing the uncinate process now. And after removing the uncinate process, we begin to probe gently in that area, and we can see that the mucosal is being seen, and it's opened and it is draining out. So all movements with the probe, with the forceps, with the suction, or with a debrider or a drill have to be done with under complete vision. This is just, I was just demonstrating how the frontal beak could be drilled out. It's not necessary in this surgery, it was just as a demonstration. Now we see that we can see the frontal sinus, and we now start opening the anterior wall of the bulla. So we've gone through the agonized cell, through the uncinate, and now we're going through the anterior wall of the bulla. And when we have removed the bulla, one starts seeing, looking, and as you can see, there's more pus coming out of the frontal sinus. And we start probing in that area, and we find an eggshell or a small shell of bone. And when we remove that, we can now see an opening of a cell behind the frontal sinus, which looks very much like the frontal sinus and is separated from it by a thin partition. And that is the supraorbital cell. So because we've removed the bulla, we can now enter the supraorbital cell, because it lies, as I said, behind the anterior wall of the bulla. So you have the frontal sinus and the supraorbital cell. As you can see, both of them are seen now, and there's a thin partition between the two. And we remove this thin partition so that the supraorbital cell and the frontal sinus are converted into a single cavity, a single wide cavity. So what you can see is, this was where the frontal sinus was. This is where the supraorbital cell was. The septum has been removed to convert it into a single cavity. And this is the anterior ethmoidal artery. And of course, we put back the axillary flap at the end of the surgery. So just to make sure that the middle turbinate does not lateralize. And you can see that the entire frontal recess is mucosalized well. There's no raw area. This is post-operative. One can see the frontal glow above the eyebrow. This is the ethmoid glow. This is the frontal glow here. And this is 4 weeks later. The frontal recess is well pneumatized. One can still see a bit of the frontal glow. This is the patient pre-operatively, and this is the patient post-operatively. So I've tried to show you a surgery which incorporates all the principles of frontal sinus surgery that I discussed so far. Now, does frontal sinus surgery always have to be endoscopic? Now, just because you have a hammer doesn't mean everything is a nail. Now, this is a patient with fibrous dysplasia, and you can see that the entire frontal recess is completely closed off on both sides. Now, if one were to drill through this bone and open up the frontal sinus, there would be a large area which would be raw bone, and it would definitely close up completely. So no matter how wide you opened up this area, even if you removed it, it would still close up. And therefore, we thought the simpler way to operate on this patient would to go by an external approach, open the frontal sinus, remove all the mucosa and obliterate it and close it. It was a far simpler and shorter surgery than trying to drill out that entire bone in order to drain the sinus endoscopically. So we chose the simpler and shorter route. Now, sometimes you can have a combined approach. You may need to actually do a combined approach. Now, this is a trauma to the skull base where there is going fairly laterally the break. And in this case, there was a leak seen endoscopically as well near the anterior fovea. This is near the anterior ethmoidal artery. That's the break. And one could also see that the break extended well into the frontal sinus So this is an external approach. And now one can see that from the external approach, we put a probe and we're looking endoscopically, and you can see that there's a large, very large break. So from the external approach, we first removed all the mucosa of the frontal sinus, obliterated and closed that area. Not the whole sinus, but yes, but so we closed off the frontal sinus with fat, and then went in endoscopically and closed up the leak near the anterior ethmoidal artery with fat and fascia. So it was a combined approach, an external approach. The frontal sinus was small, so we closed off the break and obliterated the sinus, and then went endoscopically and closed off the endoscopic leak as well. What about balloon sinuplasty? So balloon sinuplasty, I use only for the frontal sinus and only in two conditions. One, if there's a very isolated frontal sinus disease, there is no disease in any other sinus. And sometimes I've had an air hostess who had vacuum headaches every time the plane landed, and her frontal recess had actually a lot of cells, and it was a very narrow outflow tract. So in these two conditions, I would use a balloon sinuplasty. And I want to show you this case because there is also a complication seen along with this surgery. You can see that the surgeon, this was one of my residents doing it. The surgeon has actually opened up the orbit here. So what do you do when you open the orbit? Nothing, just don't use a powered instrument, don't use a suction. And here we are now putting the balloon. So first we are putting in an illuminator and checking that it's in the frontal sinus, and along that area then deploying the balloon and expanding that area. One can see that the frontal outflow tract is opened up. So like I said, very limited cases that I would use it in. And also it shows you that even if you open the orbit, you can continue to do the surgery, complete it. Just make sure post-operatively that the patient doesn't blow his nose hard. Now, balloon sinuplasty is one end of the spectrum where you're doing very minimal surgery, minimalistic surgery. The other end of the spectrum is, of course, the draft procedures. So we all know that there's the draft 1, the draft 2A, 2B, and then the draft 3. So I'm going to show you a draft 3 procedure. But because I don't do draft 3 procedures very often, I don't do them for chronic sinusitis at all. If at all, I do them for tumors. And I felt that with a tumor, it may be difficult to explain exactly how I go about. And therefore, I'm showing it to you on a cadaver. So the principle is this, that this is the frontal beak. That's the area of the cribriform plate. And you have to remove the frontal beak so that you remove the floor of the frontal sinus and the entire frontal sinus is opened up. This is the attachment of the middle turbinate to the cribriform plate. This is the most anterior attachment of the middle turbinate, usually to the frontonasal process of the maxilla. And it is at this point that the first olfactory fiber comes out. Now, it's very important to find the first olfactory fiber because you know that behind that will be the cribriform plate. And so it is a landmark that we find during surgery. So this is the kind of picture that we need. So let's get started with this. It's a little long, so I'm going to move this along a little. So that's the frontal sinus opened up on one side endoscopically. This is a cadaver. And what we do is we make an incision in the mucosa at the level of, on the lateral wall in the atrium of the nasal cavity, going above from the skull base and then coming down along the septum. And we do this on both sides and expose the entire area. The first thing that one comes across on the skull base is actually a vessel. And then beyond that, one can then see the first olfactory fiber, as one can see it there. You do the same thing on the opposite side, and then you take off make a window in the septum. So you do a septectomy, and so that you can now from one side see both middle turbinates, and you will, and on both sides you can see the first olfactory fiber. One also exposes on both sides partially the nasolacrimal system. So this is where the lacrimal system would be, and that's the skull base. And then you'd find the lacrimal system on the opposite side. These help to give you a landmark while operating. So these are the two first olfactory fibers. So we know that we can't operate behind this. We have to operate in front of this area, in this bony area, between the two lacrimal systems and the first olfactory fiber. So this is where one would need to operate. And keeping these 4 landmarks in place, one starts to drill. And as one drills further, one would open up the frontal sinus. So you're going through the frontal beak, floor of the frontal sinus, and into the cavity of the frontal sinus. Because you have those landmarks, you're not likely to open up into the brain, because you know that the 2 olfactory fibers are there and you have to stay anterior to that. And so that goes on. And you connect that to the endoscopic dissection that one has done of the frontal recess. So you connect it on both sides to the endoscopic dissection that one has done, removing so once you connect both, you continue to drill. And as one drills, one sees the entire frontal sinus. Remove the septa, which is there between the 2 frontal sinuses, and look at the cavity in the end. So you'll be able to see the bossing of the frontal lobe and the entire completely open cavity, the posterior wall, the anterior wall, and the entire frontal sinus on both sides open. I do image-guided surgery in frontal sinus surgery only when we have severe trauma and callus formation and multiple revision surgeries done before. Otherwise, for routine frontal sinus, I don't use the navigation. One last slide, and this is of an isolated blocked off lateral recess of the frontal sinus. It's completely separated from the rest of the frontal sinus and therefore developed a mucocele. And it's obviously not possible to get to it endoscopically. And therefore we do what's called a transcutaneous orbital endoscopy. This is the nose, this is medially, this is laterally. So in the eyebrow crease laterally, we make a small incision and we pass an endoscope through that area. So it's a transcutaneous orbital endoscopy. And one goes between the orbital periosteum and the bone, hugging the bone. And so what this is the endoscopic view, that's the orbital bone. This is the orbital periosteum. And we go deep to the floor of the frontal sinus, and then and you can see that the mucocele can be drained like that. And once it is drained like this completely, because it was completely blocked off from the rest of the frontal sinus, we obliterated that. So that is how one could do. We know that there are a whole lot of complications, but the most common is incomplete surgery or stenosis. But I think the one which most people fear in their initial years of surgery is the anti-ethmoidal artery tear and orbital hematoma. And I would like to debunk the myth of the anti-ethmoidal artery completely. If it gets cut, it's either bleeding actively or it has stopped bleeding and retracted into the orbit. If it is bleeding actively, it's very simple. Take your time. It's not a huge artery. It's not going to exsanguinate the patient. Find a suction, get one of your assistants to hold the scope, because now you need 3 hands, and with a bipolar, cauterize it so that the bleeding stops completely. So that's what you do if it's actively bleeding. If it has stopped bleeding and retracted into the orbit, before you do anything, the first thing one should do is press one's palm, and not fingers, the actual palm on the eyeball, and prevent it from being pushed outwards. Because if you do that, then there is no stretch on the optic nerve. So the first thing to do before you do anything is put your hand over the eyeball and press it backwards so that it doesn't come out of the orbit. Call an ophthalmologist and then decompress the orbit by removing the lamina papyrus and incising the periosteum. It's so simple and so easy to do. And I don't think one should ever be really worried about the anti-ethmoidal artery. And don't, of course, go fishing for the artery. What not to do: don't tug with Blakesley forceps in the frontal recess, don't probe blindly, don't operate in a pool of blood, don't create a circumferential raw area, and don't use too large a suction. So that's my no-nos while operating the frontal recess for frontal sinus surgery. Thank you for your attention.